Start now. Good morning, everybody. Good morning, everyone. I've just got the thumbs up, so I think we can now start. A very big welcome to our third annual Real Challenge lecture. For those of you who don't know us so well, REAL stands for Research and Economic Analysis for the Long Term. The REAL Centre, which is funded by the Health Foundation, my name is Jennifer Dixon, which I lead. The REAL Centre does a lot of quantitative analysis on supply and demand issues to try to help the health and care sector plan resources better for the long term, especially as these organisations are the biggest employers in the country. It's independent and it does fine work, so please take a look if you're not so familiar with it. And today is our annual challenge lecture, where guests challenge us out of today's thinking tramlines and inspire fresh solutions, so no pressure there on Andy. But we are absolutely thrilled to have Andy Haldane, Chief Executive of the Royal Society of Arts, giving today's lecture on the links between health and wealth, and I'll introduce him properly in a second. So on the format of today, what we're going to do is Andy will be giving his lecture for around 20-ish minutes, and then we have three expert panelists sitting in the front here who will briefly respond to the points made, and then we'll have a discussion and we'll aim to wrap up around 12:30. Now we have a really great audience, some here in the flesh, thank you, and many more online. And I'm particularly pleased to say we have a few A-level students watching with their teachers, hello, and this has been arranged through Discover Economics, so that's a wonderful initiative, thank you. So please do submit questions, and we'll get to these in the discussion. You can submit via the Q&A tab on the event platform, for those of you who've accessed that. And for online attendees, this is a box to the right of the screen where you are watching us. And for those of you in the room, this should be at the top of the page on the platform you're looking at. And you can also like other people's questions where you see them submitted, so they get to the top of the pile and I get to them in the discussion. I'm not sure you can dislike them, so I think it's just upvoting is only allowed. And also in the same location on screen, you can share your thoughts about the event via a live chat, and also respond to some quick polls that we're running in the background of today. We want to see if you're changing your mind about anything, and Anita Charlesworth, who's the director of the Real Centre, will be popping up at the end of the event to show us the results. So we're recording today, and this will be available on our website, so tell your friends, they can watch. And for anyone wishing to tweet, the hashtag is #RealChallenge. So, with all of that, let's get on to the lecture itself. You all know we face economic and particularly fiscal headwinds over the next few years. But how should we think about the asset we call health? We've seen the immediate damage to health from the pandemic and its long shadow now. And before that, we saw the impact of austerity over a decade. And underlying all of that, we saw and are only just understanding longer-run economic structural changes to society that have affected health and particularly some population groups over several decades. So the question today, I guess, is are we awake enough to all of this and the future impact on our wider prosperity? So to help guide us, I'm really delighted to introduce Andy properly now. So Andy Haldane, Chief Executive of the Royal Society of Arts, Manufacturers and Commerce, RSA. He was formerly the Chief Economist at the Bank of England and a member of the bank's Monetary Policy Committee. He was also chair of the Industrial Society Council, an independent expert group which advised a previous government. So Andy has lots of honorary and visiting posts at several UK universities. He's also the founder of the charity Pro Bono Economics and has several other voluntary and advisory roles, particularly on numeracy and social mobility. And on top of this, he's a very prolific author. So Andy, we're all very envious. You clearly never sleep and you should watch your health. This is the 6th lecture he's given in the week, I understand. So really interested to hear your challenge to us, Andy, to us all on health and wealth, and over to you. Thank you very much.
Thank you, Jennifer, for that kind introduction. Morning, everyone. Nice to see you all. The last time I was on a podium like this, actually, a few weeks ago at the University of Glasgow, halfway through, the Prime Minister resigned. That's not the plan today, as I understand it, but you never know. Depends what I say. Jennifer, thank you for your kind intro, and also for your bravery in asking me, someone who knows very little about health, to give a Health Foundation lecture about health and the economy, and that is the link today. I'm meant to know something about the economy. And today, building on the great work the Foundation does, that the Real Centre does, I want to argue not only that those links between health and the economy are deep-seated, but even more importantly, that they've never been more important and deep-seated than just at present. And then suggest, perhaps tentatively, a few ways in which both health and the economy might be improved. That's roughly the order of play. So, for those who've had the misfortune of reading in my previous speeches, you'll probably know that I like nothing more than to torture a metaphor, and today will be no exception to that rule. And the tortured metaphor today will be about society's immune system and its weakness. I'll get there via a Netflix documentary. How many of you saw the Netflix documentary on Sunderland Football Club, Sunderland Till I Die? Anyone else see that? Just me, as it turns out, and Anita. Two people. I was actually born in Sunderland. I am a Sunderland Football Club supporter. You should all go out and watch some more telly. So towards the end of that documentary, this is some weeping Sunderland supporters as their team, my team, suffered their second relegation in 2 seasons. And the question they asked themselves, why is it always us? Why is it always us that suffers these indignities? And I thought that was a great jumping off point, actually, when moving from Sunderland Football Club to UK society. So we've been asking ourselves the self-same question now for at least a couple of decades. When these global shocks have come, thick and fast, global financial crisis, COVID crisis, energy crisis right now, how is it that we in the UK always seem to cop disproportionately for those global shocks in terms of lost incomes, lost jobs, and indeed lost lives? Now, having posed that question, there are at least 2 alternative hypotheses, the first of which is just being extraordinarily unlucky, right? A bit like Sunderland Football Club, we have been serial losers in life's lottery. That's one possible interpretation of the data. But there's a second, which I argue is much more congruent with the data, which is that this doesn't reflect bad luck, but rather bad management at the policy level across a whole range of systems: economic, financial, social, and indeed health. And that's the essence of what I mean by a weakened societal immune system. A failure to invest across those systems has resulted, as it would with a biological immune system, in what? A failure to grow at sprightly rates, an increased susceptibility to shocks when they come along, and an elongated period of convalescence in the event that those shocks come along. I think that's not the worst characterisation of UK PLC, economically, socially, and in health terms over the past decade. And sitting beneath it is a weak and weakening societal immune system. So leaning into this a bit more, I'm going to think about health and other systems through a systems lens, using the analytical apparatus of complex systems thinking. Because one conception of wider society is as a nested set of very tightly coupled, closely interlinked subsystems. I mentioned a few earlier on: economic, financial, social, community, health, and others besides. And it's in the nature of complex, tightly coupled systems, that they are only as strong as the weakest subsystem, just as a chain is only as strong as its weakest link. And that's meant, as we've seen a progressive and continuing, and perhaps even accelerating, denuding of the resilience of the capitals that underpin our economic, financial, energy, and health systems, what we've seen is structural subsidence in the strength of society's, broadly speaking, immune system. Or put differently, the way to conceive of health, as we do of other capitals in our economy and society, is as an endowment, as an asset, as a source of capital that needs continuous investment and replenishment if we are to grow, if we are to be resistant to future shocks, and if our period of convalescence is not to be too lengthy. There's the punchline. If you all fall asleep from here, that's the essence of it. Here's the rough plan to give the illusion of structure to this lecture. Talk a bit about the links between health and the economy, a bit about its resilience from a healthcare perspective, and then a bit about what we might do to strengthen that resilience, both in health and beyond health, as a set of nested subsystems. Kicking off, then, with links between health and the economy. If you ever delve in to a textbook in macroeconomics, which I would not recommend to any of you in this audience, you'll find that health, at best, plays only a bit part in the standard models and textbook treatments of what it is that drives the economy. And that's bizarre in a way, because if you turned instead to economic history books, it's absolutely clear that health considerations are front and centre, have been front and centre, in driving the inflection point in living standards and other things that we've seen over the last 250 years or so. So economists like me often, for simplicity's sake, decompose the growth in an economy's potential into two components. When driving forward how much we produce as an economy or society, that can be broken down into either increases in the number of people producing stuff, that is to say, growth in the labour supply, or growth in the efficiency or productivity with which those people produce. So economics, dead easy, sources of growth, two-cylinder engines, either rises in labour market activity or rises in labour market productivity. Two cylinders of growth, and viewed as such, it's absolutely clear that the inflection point in living standards after the Industrial Revolution had a very substantial health-related dimension to it. The most obvious and direct has, of course, been that the workforce has expanded massively over that period, contributing directly to growth in the economy's potential. And accompanying, and indeed driving much of that, has, of course, been this very familiar improvement in health, or the flip of that, rise in healthy life expectancy. It's been a global phenomenon. It's been remarkable, right? After literally millennia, where life expectancy flatlined at about 40 years, that Hobbesian life, short and brutish. During the course of the 20th century, we saw life expectancies more than double over that period. And with that came increased labour supply, and with that came increased economic growth. That's the first cylinder. And just as importantly, those improvements in health, those health advances were a significant, if not the most important, driver of the second cylinder of growth. That is to say, productivity. We know from lots of evidence now that ill health, physical and especially mental, is a huge drag on workers' productive potential. And therefore, the improvements in health would have been a significant tailwind to productivity and growth over much of the period since the Industrial Revolution. And the reason for mentioning those parts of deep history is because they put in sharp relief what we have seen during the course of the 21st century. After those 3 centuries, 18th, 19th, 20th, of economics and health rising in lockstep, we've seen during the 21st century a flattening and in some cases a reversal of those self-same trends. Familiar to everyone in this audience, we all know about Michael Marmot's evidence on the slowing in rates, increases of healthy life expectancy across the UK. We know that in some parts and for some cohorts across the UK, those HLEs are now falling in absolute terms for the first time in at least 200 years. This picture speaks a bit to that evidence. And in lockstep with that, we've seen this, which is a rising both number and proportion of the working age population that are reporting as long-term sick. Those lines look pretty flat, but in actual fact, it's pretty stark what we have seen over the past couple of decades. Since 2010, not so long ago, those reported instances of long-term sickness have risen a third, from just over 5 million to around 7 million. That is an absolutely staggering 17%, or 1 in 6 of the working age population now reporting themselves to be long-term sick. And when it comes to digging a bit beneath what's going on there, one of the most striking patterns looks at the distribution of this by age, and in particular, the contribution made to this rise in long-term sickness by younger people. Those in the 16 to 24 cohort, there, the rise has been 50% rather than a third. Among that healthiest cohort, now fully 1 in 8 are claiming long-term sickness. It's the orange line in this chart. We now see as much long-term sickness among those 16 to 24 as we have among those 25 to 49. And when it comes to understanding what's driven those trends, most of the survey evidence points fairly and squarely to the rising incidence of mental as well as some physical health problems among that younger cohort, both among women, but more particularly among men. This chart just looks at some of those trends that will have translated, not quite one for one, but nonetheless concretely into rising levels of inactivity among those youngest cohorts of the working age population. Now, and that in turn will have served as something of a drag on the economy's economic potential, operating through that first cylinder, the first cylinder being labour supply. Now, the good news is in the period up to COVID, that dragging anchor from rising sickness and inactivity among young people was more than counterbalanced by rising participation in the workforce by those aged 50 to 64, the result of flexible working, elongating retirement ages, and the like. In fact, all in, the overall workforce rose by around 3 million people between 2006 and 2019, and just as well it did. Because if you decompose UK growth since the dawn of the global financial crisis into those two bits, rises in the workforce, rises in the productivity of the workforce, you find that pretty much all of the growth in the UK's economic potential has come from the first source rather than the second source. Productivity has flatlined over that period for the first time for at least 150 years, and therefore all the heavy lifting in driving growth in our economy has come from increased labour supply, and within that, the lion's share has come from this increased participation among older cohorts, particularly those in the 50 to 64 category. That was the single cylinder of UK growth, has been for much of the last 15 years. Until recently, of course, because over the last couple of years, in the light of COVID, we've seen even that prior trend go into reverse. Over the last couple of years, we've seen participation trends among that older cohort, 50-64, go into reverse. The all-in decline in the UK labour force is something between 500,000 and 1 million people. I've put 650,000 here, roughly about right, of which the lion's share has been in that 50 to 64 category. That's the blue bars in the bar chart here. And the significance of that, of course, is that the economic engine, having flown on one cylinder for most of the last 15 years, that single cylinder has now gone into reverse. We have seen a contracting workforce when that expanding workforce had been the only factor driving growth in the UK's economic potential in much of the prior period. There's been an active debate, ongoing debate, about just what the root causes have been of that increased inactivity among the 50 to 64-year-olds. You'll all be familiar with some of the studies that have come out over the past few weeks and months on that. For what it's worth, my reading of that evidence points, I think, pretty clearly towards the single most important factor being health. Here's a bit of survey evidence that speaks in that direction, asking for those inactive over this most recent period. The causes of that, and the red here is ill health. Actually, even that, I think, might understate the importance of ill health to this rise in inactivity. So the blue and the purple blocks here are retirement and caring for family and in the home. For many of those people, their second cited reason for inactivity is also health related. So for me, the evidence points pretty squarely to health having been the prime mover behind these trends. Indeed, the story here is not so much as a pure COVID effect. This isn't a pure long COVID effect. This isn't the accumulated backlog of non-COVID illness. For me, the way to interpret this is to take us back to that complex systems lens on the problem. What we have had is a long-standing, deep-seated secular trend towards ill health that I just mentioned, that's then been taken to its tipping point by the effects of COVID. Those tipping point properties are characteristic of complex, adaptive social systems such as health, and I will argue that COVID was essentially the tipping point for that system. In terms of what this means for the economy, well, it makes a difficult situation even more difficult. What had been a headwind from young people has now become a headwind from older people. What had been the single cylinder of growth in the economic engine has now gone into reverse gear. It should come as no surprise to anyone in this room that we therefore see macroeconomic headwinds such as a record number of unfilled vacancies. We haven't got enough people. That we should see staff shortages the length and breadth of the country in each and every sector of the economy. And of course, what those staff shortages will do is to accentuate and to elongate the cost of living crisis we are all living through. And even that, as if that were not bleak enough, probably, almost certainly in fact, understates the damage done by these secular trends in health. Certainly for people's well-being. We know that ill health is the single biggest detriment to well-being. All the evidence suggests that COVID has caused a further down lurch in those well-being metrics. And all in, where this leaves us is a situation where, for the first time, probably since the Industrial Revolution, where health and well-being are in retreat. That having been an accelerator of growth and well-being for much of the last 200 years, health is now serving as a brake in rises in growth and in well-being of our citizens. That is the significance of this moment. That is why health matters, not just in some abstruse sense, but particularly so given the confluence of trends and shocks we have faced over the recent period. Which begs the obvious question, can we cope? In other words, is our health and healthcare system sufficiently resilient to bear up to these trends, some long-standing, some recent? You'll guess by the way I've toned that question. The answer's going to be no, isn't it? Here's some diagnostics on that. I could have picked loads. Many of these will be familiar to many of you. You could look at those rising disparities in healthy life expectancy between different cohorts. This picture looks at that. We know there are profound differences in levels of HLE between different areas of deprivation of the country. That amounts now to around 15 years. To such an extent that, you know, in the most deprived parts of the UK, both men and women are living as much of a third of their lives in ill health. Absolutely remarkable. We know when it comes to spending on healthcare systems, at least by G7 comparisons, the UK sits towards the bottom of the pack, a bit like Sunderland Football Club, threatened by relegation from the G7. We know that when it comes to numbers of doctors or numbers of beds per head of population, the UK, the red dot here, occupies a relatively unenviable position after a number of years of relative underinvestment in both of those things. I think the King's Fund estimated roughly a 50% fall in NHS beds over the past 30 years. We hear almost daily about the rise in waiting lists and the rise in waiting times for various forms of clinical intervention. This picture may double count some, may overstate the rise, but nonetheless, the rise is unmistakable. For those waiting more than a year for treatment, we've seen those numbers rise from a little more than 1,000 in 2019 to something like 400,000 today, the most vertiginous of ascents. I could depress you further with diagnostics on this, and maybe I will in the Q&A. But for now, that's probably enough to make the case. On current projections, those problems in occupancy those problems in satisfaction are unlikely to solve themselves anytime quickly. Most projections point to them worsening over time. And what at root this points towards, of course, is the degree of resilience, the degree of redundancy in health and healthcare systems has been reduced progressively over time. The fragility of that system has increased over time. And not just health systems. We know that aiding and abetting those rising fragilities in health have been rising fragilities economically and socially as well. I mentioned some of the aspects of that too. We know that many of these health problems are seeded early in life among people in their 30s or their 40s, indeed often during the childhood years. It's therefore sobering context that UK PLC has levels of childhood poverty that do not bear favourable international comparison. It's relevant that when it comes to spending on children's services, we've seen not just a real decrease in that spending across all cohorts, that's comparing the red and the green bars here, but those cuts in spending on children and young people services has been largest in the most deprived parts of the UK, to the point today that we spend no more on those services in the most deprived parts than we do in the least deprived parts of the UK. And if we went from children to more broadly based economic and financial fragilities, we know that they have been high and rising for the better part of 15 years, made worse, no doubt, by the ongoing cost of living crisis. And we also know from evidence, including from the RSA before my time, that that rising tide of economic and financial fragilities has shown up directly in those mental health problems, in particular among younger people. Enough diagnostically. Let's go to some prescriptions. On this, I am necessarily going to be a bit more speculative, but I hope at the same time still challenging to some degree. There is no single measure or policy that will turn the tide, that will strengthen the resilience of UK health and other subsystems. But from a potentially long list, let me just mention one or two that for me directionally would push us closer towards a somewhat more resilient picture than the one I've just painted. And the first point to make is a rather arid one, but I think nonetheless important one around measurement. If nothing else, COVID demonstrated the importance of effective measurement if we are to put in place effective and timely remedial policy measures, to such the point we actually probably overshot the point where COVID stats were the news. The key point is to not lose sight of some of that when we enter peacetime as distinct from wartime. Because right now, when it comes to keeping score on societal success, we give loads of focus to wealth, but far less to health and happiness when figuring out how we're doing. And that, for me, needs fundamentally to change, that looking forward, a new national accounts would measure clearly and accurately all the capitals, not just human capital, people's skills, not just physical capital, machines and technologies, not just social capital, trust and relationships, but health as an endowment and capital as well, and view them as one, as distinct but interrelated subsystems in securing and strengthening society's immune system. Second, in my previous gig at the Bank of England, I spent a lot of time thinking about the fragility of finance. And one of the key lessons of the global financial crisis is if we are to adequately risk manage the financial system, we need in advance to subject that system to stress tests of various types, to figure out just how much redundancy and resilience it has. What is true of health, of finance, is no less true of health. That was done in the teeth of COVID. It now needs to be systematized and regularized when it comes to assessing the resilience of health and healthcare systems. This is a place, Anita, Jennifer, where I think the Health Foundation and REAL could play a significant role on the measurement and analysis side. There's some great work recently, to go to my third bullet point. How long have I got, by the way? I haven't seen a card yet. 1 minute. I didn't see the 10-minute card. There you go. I will speed up. On how devolution of health in Greater Manchester made a massive difference, made a difference to health performance. Not surprisingly, local problems, health or otherwise, typically necessitate local agency and local information. This speaks strongly to us giving the hurry up and the giddy up to the Devo agenda, not just for health, but for other reasons as well. Let me jump ahead a bit, given my 1 minute. On food standards, we have fallen well short of the recommendations set out by Henry Dimbleby last year. That feels to me, given these trends, like a hugely missed opportunity, one we can ill afford to miss looking ahead. Given those trends in young people, is it the time to rethink about what is done in each and every school across the country? Is there a case for having a nurse in every school, not just providing, if you like, the health education, but the broader community and pastoral care that's needed in schools? A mini campaign that Sam Averington, architect of social prescribing, has spoken to. When it comes to business, and John will, I'm sure, speak some more about that, we've seen business sitting up and paying much more attention to these matters over the past 2 or 3 years for understandable reasons. That needs to continue. This thing, ESG, the environmental, the social and the governance, perhaps needs a letter adding to it, which is the health dimension, the role and responsibilities of business in securing the health not just of their staff, but of their customers, clients, and communities as well. We have, as we all know, an autumn statement coming soon. Some tough choices to be made, no doubt. One dimension of those is how, when we're doing the budgetary arithmetic, we think about divvying up the spending between the current and the capital expenditure. This is super relevant because much of health spending falls into the former bucket, current spending rather than capital spending. But if you buy my diagnosis of how we should think about health, which is as an endowment, as an asset, as capital to guard against future healthcare problems, that allocation of spending may make much less sense. The right prism for viewing spending choices right now are the implications they have for long-term wealth, health, and happiness. And current statistical distinctions do not make that distinction sufficiently precise or clear. Given my -1 minute, I reckon, I'll not dwell on the last aspect, which is rethinking and refashioning the protection we provide to people young and old when it comes to guarding against those financial and economic insecurities which loom ever larger as they have over the past 15 years. Let me wrap up. Does it matter, health? Of course it does, and of course it always has. But my reading of the runes is it's never mattered more than just at present, given the secular trends and the more recent shocks that both our economy and health systems have faced. There's no question right now that those healthcare trends are serving as a significant headwind to growth in the economy. They are amplifying that cost of living crisis. They're making more precarious our fiscal finances, both today, but particularly in the future. And ultimately, they are also reducing our susceptibility to future shocks. The one thing we say with certainty is that those future global shocks will come along, perhaps even as thick and as fast as they have over the past couple of decades. We cannot afford to find ourselves in a similar position of fragility in the future. Guarding against that will require a replenishment, a rebuilding of all the capitals I've mentioned, including significantly the often overlooked capital or endowment that is health. I've suggested one or two ways in which that rebuilding or replenishment might take place. Why is it always us? Let me end optimistic. It need not be. The diagnosis is pretty clear. The prescription is also pretty clear. We can avoid this, and for me, we absolutely should. Thank you, everyone, for listening.
Thank you very much, Andy. Masses of food for thought. We're now going to turn to our lovely panellists for a brief response before having a fuller discussion. So let me just briefly introduce our panellists. We have Jordan Cummins here to my left, who's the head of the health programme at the Confederation of the British Industry. Next to him we have Dr. Ricky Kanabar, who's an assistant professor in social policy at the University of Bath. And next to him we have Jill Rutter, who is known to many of you, former IFG, Institute for Government, now the UK in a Changing Europe, but also an iconic civil servant who's worked for many years in different departments, not least the Treasury, and Number 10. So we've asked them each to give a 5 or 6 minute response. So I'll start off now with Jordan. Thank you.
Thanks, Jennifer. Hopefully everyone can hear me. It's brilliant to be here. Following Andy is a pretty tough gig, so I'm going to give it a go for everyone to keep it relevant. For those of you who don't know the CBI, we're the biggest business body in the country. We represent about a third of the private sector workforce, so we're very well ingrained. Usually you'll see us shouting about the economy, and we still do all of that. But actually coming out of the pandemic, there was a big push from industry leaders, actually, that the CBI should kind of weigh a bit more proactively into the health space, not just about managing the immediacy of COVID, but about the forward resilience of our workforce. And so that's what we've been doing for the last year. And so when Andy was talking about stress testing, the resilience of the workforce, the levels of inactivity, the staff shortages, that's our bread and butter. That is what business leaders tell us every single day. And the policy implications, I think you're right, are pretty grave, and it's tough to say, but most of them won't happen in our lifetime. So biting all of this off in one isn't going to be possible. So we should probably be quite honest about that. And it's not all government's job. So I think, as Andy mentioned, there's a fiscal statement coming soon. There are going to be tough choices. We can't just turn to government for fiscal firepower anymore, so we've got to get creative about how we solve some of these problems. And so for us at the CBI, we're trying to capitalise on what we think is quite a golden post the immediacy of the pandemic window. Something rare happened at the end of 2020. Trust in business went up, and I've been at the CBI long enough to know that that doesn't happen lightly. And it happened because, for the first time ever, the decisions that bosses up and down the country made a huge impact on people's individual health and well-being. They could draw the line between the stuff that happens in the boardroom and how you feel as an employee. And that was hugely powerful. It really reformed how lots of people thought about how they take care of their workforce. And so from an industry sense, we're in a really new place. Before 2020, we probably didn't value health enough, definitely. 131 million working days lost to poor ill health. That's obviously only got worse. And we've got the conflation of things like long COVID, new conditions to manage in the workforce. So this is tough for employers, but they're coming at it in a different way. And that is why it's really important, I think, for us to be in the debate. It's why we're delighted to be invited. And it's why we want to talk a bit more about what we do. So to pick up a couple of bits to reflect on what Andy was saying, in Inactivity and resilience, I think, are the two big ones for us, if I was just to pick a couple out so that you don't have to listen to my non-dulcet tones for too long. If we take inactivity first, so the levels of inactivity due to ill health, as Andy mentioned, are at a 20-year high. The volume of people now who just physically can't get themselves back into the workforce is causing real structural issues for the way firms are being run. And when you conflate that with a lack of supply-side reform that we'll probably have on immigration at the moment, we're having to get more, as you say, from less people. We're having to rely on productivity rather than volume, as Andy quite neatly outlined. And so where do you go if you're a business who's looking to get more out of your current workforce? Well, there's actually no single place in the country where you can kind of benchmark your offer. If you're sitting there and you're a manufacturer in the northeast versus another manufacturer in the northeast, it's very difficult to know all the stuff that you pay for is actually helping, number one, and is competitive, number two. And so the CBI are weighing into this space next week by launching something called the Work Health Index, where we think it will be the first time ever for every business in the country to kind of benchmark what they're providing from health and wellness from a health and wellness perspective. And it will help you in this really tight labour market. And hopefully in the long term, it will start to take every business in the country on a journey to amp up that offer. The flip side of it is if you're in government, you've got no idea what's being offered in the private sector. It's very difficult as a data set to get your hands on. So the reason we've got the NHS and government on board to support is because the data is hugely helpful for them in terms of policy making. So on inactivity, there's some investment I think that firms need to kind of lead on, and we need to use this golden window post-pandemic to kind of get people on that journey. And on resilience, a couple of points on that. I think the why is it always us? You can probably say that as well if you're a clinician sitting in the NHS, or if you're a business sometimes and there's no money from government to solve something. You probably also turn around and say, why is it always us that has to pick up the bag? But the problem is, government can't solve all of this, and you will have to do it in partnership. We can't get away from that. And so the stress testing idea, the resilience, the kind of government setting the frame, industry coming along to innovate, making sure that our system can kind of work going forward is hugely relevant to us. And I think there are levers that can be pulled. You know, if you think about health investment from a government perspective, the NHS has huge purchasing power. The NHS can make a huge difference to the way that industry engages with the state en masse. You've got a new kind of ICS structure to work with. There are ways in for business now that there perhaps weren't before. And so that resilience has got to come with a kind of long-term partnership focus. And some of the work we've been doing with business and government has really shown the eagerness to get going on some of that. And then just a few comments from me on kind of how this feels for industry, how they would react to kind of some of those seismic policy changes if we were to do them. If you look at if you look at climate, 5, 6, 7 years ago, I'm pretty sure I was sitting on panels talking about the need for climate to be a competitive advantage as well, and to move away from this just feeling like a cost for industry. How did we get there? Well, we got there because government turned around and said, look, one thing that is in our control is regulatory frames, is encourage people to innovate within a kind of structured framework. Go away, industry, tell us how we're going to make it to net zero. And boy, did they. We just don't have that in the health space. And so some of the work that we've been doing and thinking about is about kind of healthy working life expectancy. We've just seen how HLE is going up for everyone, and everyone's state pension age is tied to their life expectancy, not necessarily tied to their working life expectancy. So there is a growing gap, especially among men actually, between when you have to leave the workforce due to a health issue and when you're going to start getting paid for not being in the workforce anymore. That's a big issue. We need to start thinking about smoothing out people's work journeys. So that we're not all burning ourselves out in our 20s and 30s and then lurching our way to retirement in our 50s and 60s, because the way that the ageing population is going is just going to make that completely infeasible going forward. So a little bit from us in the kind of next few months that you'll see from us is on kind of healthy working life expectancy, how we can set a kind of climate-esque target using the ESG framework, Section 172 statements, all of this stuff that business has to do on a day-to-day basis. These are kind of levers that we should be pulling in partnership rather than government just saying, do this, business saying, well, I can't. If you co-design some of this public policy, you can be in a really great space, which is exactly what happened on lots of the market-making stuff that needed to happen for climate 5, 6, 7, 8 years ago. And so those parallels are the ones I think we're quite keen to make. And with my 1 minute that's now gone, I'll maybe leave it there.
Thank you very much, Jordan. Very, very good to see the CBI stepping up here in the seize the moment post-pandemic space. Lots of questions on business, but we'll turn to the other panelists and come back to those questions. So And now move on to Ricky Kanabar.
Thank you, and I'll abuse my panelist privilege and say I'm going to take about 7 minutes, okay? Sorry. So I want to thank Andy. It's always a pleasure to hear you speak and hear your thoughts. So I think it's a very thought-provoking and interesting lecture. Many of the points you raised reflect challenges we face as a society and underlines the importance of data and evidence to inform decision-making. Health, in its broadest sense, is a policy area that has the potential to affect an individual's living standards throughout their life. And indeed, poor health, or shocks to health, often lead to what economists refer to as scarring effects. And such scarring can affect a range of social and economic outcomes. And this, indeed, underlines the need for a holistic approach to policymaking in order to understand how interventions or mechanisms are likely to impact not only expected outcomes, but also to consider spillovers and indirect effects. So I just want to reflect on your lecture a little bit before I come to my own thoughts. I'm going to admit that we got to see some of your notes beforehand, so you only just kind of covered this towards the end of your lecture, given the time constraints you had. But I think the idea of your regular stress testing on the health system is a good one. My concern, I suppose, is, aside from the additional resources and time for already stretched NHS staff, is the solution versus what's feasible. So, for example, if we cast our minds back to the financial crisis, and as you well know, the changes banks made following this was to raise their capital holdings, to cushion shocks, provide liquidity. In a large part, financial institutions had the resources to implement this change. So if, say, such stress testing on the NHS highlighted the need for equivalent measures, i.e. more funding, how palatable, feasible is this? If instead the issue is staffing, then it takes years to train doctors and nurses. So should policymakers be thinking about skills, training, incentives, investments, indeed immigration? So some thoughts on this would be welcome. So I'm now going to talk to you a little bit about my own work, for example, with Paul Gregg, who was recently on the Social Mobility Commission. And we analysed the extent of wealth transmission in Great Britain. And we showed the importance of parental wealth in determining offspring wealth. And our findings suggested that parental wealth explained about 1/3 of the variation in offspring wealth. So comparatively speaking, this is slightly lower than studies which have studied the same question in the US, and slightly higher for those who've used data from Scandinavian countries. Moreover, we worked out that the strength of this intergenerational correlation will roughly double in about 6 decades. Okay? So things are set to get more unequal. Indeed, an IFS report this morning showed that wealth inequality has indeed increased significantly, especially when we compare to stagnating real earnings. So things are set to get more unequal. In the same way, research funded by the Health Foundation highlighted that health inequalities emerge at young ages and are already visible at the time a child reaches adolescence. For example, severe obesity rates for 10 to 11-year-olds in the most deprived areas are 4 times those in the least deprived. And such inequalities exist later in life. ONS data show, as you showed in your slides, males living in the most deprived areas live on average 9.7 years less than those in the least deprived. So put another way, one could almost flip this year's real lecture title and ask the question, wealth is health. Should that be the case? And of course, things are not that simple. So Andy's lecture and existing research, including that carried out by the Health Foundation, has a number of implications for social policy. From a first principles perspective, good health is a precursor for contributing towards well-being, academic achievement, labour supply, productivity, and more generally contributing to society at large. However, as I just mentioned, different groups in society do not report the same levels of health. Indeed, health is stratified along a number of dimensions, and overcoming regional and indeed local level health inequalities is a major policy issue, which Andy has alluded to. There are also a set of health issues, or health challenges, which, whilst not new, must be addressed if we are to improve our nation's health. Andy already mentioned striking statistics relating to waiting lists and mental health. Andy also mentioned the importance of resilience of the health system. And I want to draw attention to the fact that the resilience of the NHS and its ability to adapt to any given shock would largely rely on its workforce, on the NHS workforce itself. So policymakers must strive to improve and maintain high levels of well-being amongst NHS staff. This is an area policymakers need to better understand and address, and it's not simple. Recent IFS research showed that decision for workers to leave the NHS is complex. A nurse or midwife who missed 3 days of work for mental health reasons was 27% more likely to leave 3 months later compared to a peer who reported no absences. For a consultant, the difference is 58%. There is a large body of research which shows work conditions and workplace environment can impact productivity and workplace retention rates. And I'll be black and white here. Pay also matters. I also was asked to consider policy levers, which could be used to create a healthy society and address some of the issues just discussed. This is no mean feat in the small amount of time I have. Nonetheless, what does the evidence tell us? Existing research highlights the importance of early life interventions. Recent IFS research evaluates the rollout of Sure Start and highlights a program that had a positive impact on lowering hospitalisation rates. Importantly, the work stressed and highlighted the integration of health and non-health services, and to better understand the mechanisms by which interventions lead to particular outcomes. However, spending on Sure Start centres has dropped by 2/3 in the last decade or so. So I also think policymakers need to reconsider the design and role of health literacy. Okay? There's lots of research in this area, quite a contentious issue. There's not much action, well, not sufficient action on the policy front. Okay? So there's scope for integration with formal curricula. We need to interact with young people, intervene early in life. The role of parents, thinking about collective responsibility, and also local level initiatives, or indeed hyper-local level initiatives. Okay? And we had policies in the past which indeed may have been fruitful in this area, for example, the health action zones. Even the existing programs, Change for Life, the Core 20+5, we're still seeing obesity rates, for example, rise rapidly. We do need to work towards a system of health disease and prevention. I completely agree. But health behaviours and habits are obviously established at young ages, or especially adolescence. Separately, and I'm coming to the end, I'm wrapping up now, health literacy is not just relevant for young people, but for people of all ages. So why shouldn't we have lifelong learning with respect to health, okay? The role of local champions leadership, emerging with the right, linking up with the right stakeholders, these are doctors, frontline staff too. What works? Do we have a consensus? Okay, can the What Work centres help here? I always think we need to be mindful and realistic of the current fiscal environment, even though we should consider health interventions, investments in the as long-run investments to society, I agree. So prioritise those investments which are based on strong evidence among potential alternatives. Also, policymakers must think about health beyond the electoral cycle. Okay? These health inequalities are clearly entrenched in society for a long time. And this is indeed the approach in other countries I work in, such as Scandinavia. My final point is on data. Okay? As a researcher, data matters. This is true for any area of policymaking, and health is no exception. Government should utilise existing administrative data registers to improve decision-making. This is cheap. They collect the data anyway as part of their departmental norms. Okay? Integrate register data further, precisely because policy areas such as health are cross-cutting. And finally, make access to such registers readily available to researchers. This is, again, much more common in Scandinavia. Whilst this is beginning to happen here, we have a wealth of data which is underutilised. Thank you, and I'll hand over to Jill.
So thank you, Ricky. And you're very interestingly pointing to wider aspects of social policy that would be included in a resilience assessment or stress test, which, again, many questions on that we'll come back to. So, Jill, your response, thank you.
Okay, well, I'll try and come in slightly under so that we have time for questions, but my watch isn't working, so I might not be good enough at that. So, first of all, there's one thing on which I really, really agree with Andy, and I'm really pleased he said that, which is our bizarre approach to what we count as investment and what we count as current spending. To take it further, I mean, Andy suggested that actually we should regard investment in health as capital spending and treat it like that. It always struck me as very bizarre that we don't regard education spending, which you'd have thought in spades is paying off in terms of long-term productive capacity in the economy, that you build a school and that will count as capital, you pay the teachers and that counts as current spending, and therefore is squeezed. But I'm also going to take one issue with what Andy said, which is at the end of his very, very interesting and thought-provoking talk, he defaulted back to talking about the healthcare system. Now, he wasn't just talking about the NHS, but there is a real danger, and there's a real danger that we see as we approach the next spending round, that we equate healthcare with the NHS. If you look at the figures for public spending over the last decade, people inside the NHS will say it's been really tight, we've been squeezed. That's one reason why we entered into the pandemic in a relative state of unpreparedness, and there's some Institute for Government work which shows that. It's why we're a bit threadbare and we were running hot all the time. What is efficiency in normal circumstances becomes a lack of resilience when you put a system under any pressure. But the problem is that every other budget suffered more than the health budget, with a single exception of overseas aid, because health was protected and others were unprotected. And you see that. So increasingly we have a public spending system where health takes a greater and greater share, and it looks as though we're going to do that again. And within that, we put more into the acute system, into hospitals, rather than to the bits that we know would have probably better long-run payoffs, whether it's primary care or whether it's prevention, which are the relatively easy and lower profile bits to cut out. And other services, which might actually offer better long-run prospects for health, but don't have health in the name, do really, really quite badly. So, one of the things Andy mentioned was, had cuts in short start, as Ricky mentioned, children's services, youth services, those don't come with the magic words of health attached. And therefore, those budgets are very vulnerable, even more vulnerable if those are provided by local government. And I think one of the problems with health is within this, it's part of a story where we're increasingly skewing public expenditure, and I speak with a vested interest here, towards older people, that increasingly we have as public spending bias towards the NHS, which is increasingly occupied with providing care for people as they get older. We see that the government may postpone its commitments on social care, but those are about preserving resources available to older people to pass on to the next generation. We probably see that the government will maintain the triple lock on the state pension, and we have quite a lot of bits of other untouchable pensioner welfare that people throw in and then governments find uncuttable. And the real problem, I think, here is that even in normalish circumstances, peacetime, we're unwilling to have a conversation about whether we are prepared to hike tax levels enough to enable us to have a health service that we are comfortable with as providing a decentish level of care, whether we're willing to ask some people who can to make some sort of private contribution, because Andy's figures was on sort of NHS beds as opposed to total beds and things like that. Because one of the things that is well known about the UK economy is that we like European levels of public services, but we prefer to pay US levels of taxes. So I think the question is, are we prepared to have a government which is prepared to have that difficult conversation, but it's also prepared to have some of the difficult policy conversations? We saw a brief moment under Therese Coffey when she binned the obesity strategy. Is the obesity strategy back there? Some of the Dimbleby things, some of those earlier interventions and budgets, and for people working at places like the Health Foundation, people working in the NHS, are you prepared to have a bit of a harder time in order to divert resources into places where there may be a bit of a longer run payoff?
Thank you very much, Jill. Great, so lots and lots of questions. Thank you very much for those. Please keep submitting them. Perhaps I can start off with an opening one. I mean, why is it always us? I mean, you could ask a different question and say, why haven't we been looking hard enough at these trends that actually have been there if we could only look? And why haven't we seen them enough to act? So given that we will talk about the long term in a minute, but we have, as many of you have referred to, a moment coming up on the 17th, the week after next, where 55 billion is to be found somehow or other. How can we protect this capital? What are the best arguments that can be used in the short term, even maybe over the next couple of years until the next election, to try to offset some of the damage that could be done, and particularly amongst the young is looking at those figures. So who'd like to have a go at that? Why have we got this cognitive blindness? Is it still operating? And what could we do in the short term to offset some damage that would otherwise surely be done?
Go on then, I'll give it a go.
Thank you.
Rookie mistake from me. I think Jill's point about where we channel money, in especially prevention, I think is a fantastic place to start. So if 70-odd% of the reasons people end up in hospital are preventable reasons, the evidence base doesn't need to be redone again. We don't need more reports or analysis. We just know that we're not spending enough in the right places on prevention. And so if we can't rely on fiscal firepower again, and the NHS and other parts of the state system physically can't do prevention and the immediacy of care, which we know they can't because they keep telling us they can't, if you want to hit people en masse, there's not many other places to go than industry. Most people in this country work in industry. If you want to touch people en masse and you want to get to them upstream, you're going to need employers to start doing something. And that means you're going to have, as we've said, some kind of knotty conversations about it's your responsibility for my health versus it's your responsibility for my health. In reality, it's everyone's responsibility, but we're going to have to weight it probably a little bit differently going forward. And so I think for us, there are some really great things that government can do in terms of signals on how they're going to work with industry, specifically on prevention. that don't necessarily have to cost loads of money, but it will probably need a bit of a kind of reset of that balance of responsibility. Taking it out of the parliamentary cycle, as you said, is really, really important. This needs to be a cross-party effort, some kind of national commission. Now, I'm not calling for any more talking shops where nothing gets done, but if you're going to get to that co-design phase, it's going to have to be non-political and go beyond the next election. And I think you could kind of start with a resetting the contract, national accounts type conversation in the next year before we get into campaigning mode. And business would be hugely welcome. So I think leaning into the prevention bit and using industry as a lever more proactively, rather than just looking at them as a source of the determinants problem, is probably a decent place to start.
Thank you. Who else wants to go? Particularly the NHS is the Achilles heel. You can see how money would be siphoned more to there, but it's these wider determinants that could get lost, couldn't they?
So I think a really interesting question on the two big phenomenon. One is the withdrawal of the sort of older cohorts from the workforce. I think there it's really important. I know the ONS is doing work on this to really dig down and understand actually what are the characteristics of that and why are people going, because until you understand why people are withdrawing, and I know people are worried in the Treasury about that, because you have people who are withdrawing from the workforce now, hitting productivity, hitting growth, things like that, but also storing up longer term problems, because people will end up with fewer resources in older age and therefore less resilient there. So it's both a short term problem and a long term problem. But I think you need to understand, why that. So some people have suggested actually you need work coaching to get people back. Well, that's different if people are actually physically unable to work because they're waiting on a waiting list for an appointment to have, their arthritic hip replaced, and they can't, want to do physical work and they can't do it. So I think there's a really sort of important sort of understanding about what's in that cohort. The really interesting thing, and I think that really requires much more understanding, is both what is behind the surge in mental illness in younger people. What can be done with it? In terms of prevention, what should we be doing to prevent the next generation of coming in with those problems? But also, how do they need to be supported in or around work, or in or around higher further education or whatever, to make sure that we do that? Is that about changing employment laws, reducing sort of precarity there? What exactly is the problem there? And what services they need, but also what prevention methods. But I'm not sure we know enough about that yet to do that. Do we know that? Looks at Jennifer or Andy.
I mean, in terms of what might be preventing government from acting, other than money, of course, is it that there isn't the evidence to make those links that are fruity enough to spur action between health and wealth? Is it because the evidence is there but the will isn't there? Or is it something else that we need to tackle? Because we can just see this going on, even with the short-term acute story from COVID that Andy points out very well, is becoming more stark as to what's happening to the health of the population and the workforce, on top of existing trends, which you showed, long-term secular trends, are all in the wrong direction in terms of workers' health. So what is the... in other words, what I'm trying to get at is, what is the short-term key that could at least spur some more immediate action when you're staring 55 billion in the face? The need to make up that.
Is that me, Jennifer?
I think it is, yes.
Thank you. Well, you divvied up your diagnosis two ways, and one was lacking the evidence of the data, and the second was lack of will rather than data. I think the truth is it's both, isn't it? I mean, the fact that we're still having a debate about what actually has caused this rise in inactivity among the 50-plus-year-olds is evidence enough that we haven't fully got our heads around the measurement aspect of that, and we do know that that which isn't measured tends not to be managed, and that is part of the story of why we are where we are. That's partly a question of, at what horizon you get a payoff for various things. We don't have anything equivalent to intergenerational accounts, given that maybe the biggest inequity we face right now isn't so much income or spatial, but probably generational. The fact we don't have that is a significant drawback to making the right choices today for future generations. That will always be a problem, of course, because we know that the timelines of the political decision makers are themselves short, measured, used to be in years, I think it's now measured in weeks. There's no perfect antidote to that, much more Jill's territory than mine. But I do think I look to what Wales are doing with their generational act.
Legal system too.
So having an eye, being required to have an overt statutory eye on your endowment to future generations, whether that is in terms of health or in terms of income or in terms of climate, I think is a useful discipline. Not a perfect discipline, but a useful discipline, and one we could maybe learn something from.
But one of the things I think is very interesting is where if you look at the Department of Health sort of research budget, is how little and how uninterested the Department of Health is in prevention or whatever. There's huge amounts of money that goes in, obviously privately funded, into research into treatments and things like that. But actually, I remember this comment, it may have changed, but I remember the comment from Dame Sally Davis when she was Chief Medical Officer, that very little of that budget goes in to looking at prevention. That means when NICE comes to recommend prevention things, their sort of general line used to always be, I haven't looked at this for a bit, which was, there's very little evidence on this, but it's so cheap and the potential payoffs are so big, it's a bit of a no-brainer, which maybe is where you are on those things. But I do think that the Department of Health, maybe this sounds very Andrew Lansley, Department of Health, feeling that actually it does have a sort of really big cross-government role, advocating for health. I think Department of Health is really quite a weak Whitehall player in that. It's very, very effective at protecting the NHS budget, but it's very poor at engaging with other government departments and influencing where they go. Some of that goes to political appetite, though obviously, you had moves with Sajid Javid setting up his Office for Health Disparities, but then gets disbanded, or whether it's actually been disbanded, or whether it's in cold storage somewhere, has been resuscitated with Steve Barclay. But I mean, that sort of lack of commitment, I think, in the Department of Health to think that long-term population health is their big interest, as opposed to ensuring adequate resources being devoted to the NHS.
Yeah.
Just on that, sorry to jump in, Jennifer. So I think redemption will not come from altering the Whitehall machine. I think it'll come from power being decentralised from the Whitehall machine to the local level. You will not have a joined-up conversation about health and the economy and finance and energy at the Whitehall level. Never has happened. I imagine never will happen. You can have that conversation, and it's happening at the local level.
Yeah.
Then you have a chance of a joined-up story about the different arms of policy, the holistic approach that's been discussed by everyone, and I imagine I would find favour in the room as well. And then there'd be a chance, I think, that you could do some local experimentation. So if an area went down the preventative route and said, I'm going to allocate my budget in a very fundamentally different way, others could look on and observe, we could exposed to evaluate that and learn from that experience and hopefully emulate that experience if it proves to be successful. So for me, that's why I mentioned, albeit en passant, the importance of the, broadly speaking, DEVO, decentralisation agenda here, not just for health, but for other things besides. I think without that, you won't get the join up and you won't get the experimentation. You'll get the stasis that we see.
But it's quite interesting because actually Scotland and Northern Ireland are worse performers than, markedly worse performers than England. So it must be your level of devolution. So if you think devolution is the sort of bullet there, I mean, Northern Ireland is the size of a reasonable sized local authority. It's no bigger than that.
Quite so.
It has its own executive problems.
I think those differences, are themselves interesting. Of course, in the course of experimentation, the whole hope is that you get variation in performance from which you can learn. We do now have some variations in performance from which we can learn what works and what works less well. We need more of that and less from the centre, I think, to break into this.
Yes. I mean, one of your points, Andy, was about having a national accounts reckoning of health, actually putting this in the national accounts. But I'm thinking in terms of a national level, nobody really monitors the health of the population on a regular basis and, for example, reports to Parliament in the way that the UK CCC does on carbon. I mean, it took us as an independent foundation to decide to fund Marmot Review 10 years on, for example, to do a reckoning of health, the health stock of the nation. So even what you say about local authorities is good, and indeed businesses stepping up to the plate. But should there be a national accounting, a national audit, if you like, of the state of health on a regular basis, not least because the government itself has set a target, hasn't it, of increasing healthy life expectancy by 5 by 2035. So should this now be happening and reporting to Parliament, which presumably would help the industry as well, and set the scene for some wider social policy that might build resilience to support wider health? What do people think of that idea?
I think it's my point, I guess, and I was going to say it in response to your previous kind of question, but data matters here, right? We can tell a very powerful story with data, whether you're talking to policymakers, other academics, audiences like today, and tell a narrative. And twofold, it's for accountability reasons too. In the same way Andy just said, hyper-local level or local level interventions are good because you can actually identify which, if you're trying to understand, an intervention, its mechanisms which matter, right? What's actually leading to the change, the behavioural change, the social change we're interested in. And also, who should be held accountable if something's not working, right? If the system's only as strong as its weakest link, then you can identify that if things are kind of local level. So I think just to this point, why not take, I in the past have worked with government to help them report poverty levels every year. There's no reason why health is just as important as income. Why not have some kind of regular reporting framework to indeed hold government, local level, regional level, local level partners accountable?
I was in DEFRA when we did the original Climate Change Act with David Miliband, which had sort of two components, one of which is setting a legislated target on whatever, first and 80% emissions reduction, now net zero. And then, because DEFRA was always a very weak Whitehall player, and we found it very difficult to get other departments to buy into our agenda at all. We'd squeak from the sidelines and we do these great strategies where lots of measures by DEFRA and none by anyone else because we're down the heap. So we created the Office of Climate Change, was in part to sort of give a bit of extra oomph on departments. Now you can see from actually the progress of the Office on Climate Change that the UK has been very successful in decarbonising the power sector, which was the responsibility of the department that also had climate in its title as both DEC and then into the Business and Energy Department. It's been much less successful on areas like transport until Grant Shapps was Transport Secretary, on housing, things like that. So it's not an absolute panacea, but it does mean that you actually crystallise a sort of discussion about that. And you have people who can actually externally be saying, here are some of the levers you could be pulling. One of the problems, I think, in this, though, is, we both mentioned this IFS study on Sure Start reducing hospitalisations, but that was produced about a year ago or something like that, and that was looking at Sure Start, and it was, so it's about a policy that ran to 2010 and then ran into the ground. So it takes quite a lot of time to have evidence based on what works and what doesn't work, which I do think is a problem when you're talking about some of these long-run determinants because it's so intractable. But I think, I'm a great fan of independent institutions helping inform the evidence base of the discussion within government and within local government, and actually be pointing to people who want to do the right thing. Actually, have you thought about these possibilities? These are things that have worked elsewhere, so you don't have to relearn from scratch every time you want to do a policy innovation. Quick copying is much better. Quick copying and adjusting to your local service is much better than thinking, oh my God, no one's ever done this before, when lots of other people have.
And just, yes, something.
Just to comment back on, kind of related to Jill's point and my previous point. So here, of course, measurement and data matters, right? If you're having this idea of having this regular reporting, you need to ensure that you have the right data structures there to actually, are you measuring the right thing? Yeah. So of course we have Health Survey for England, but also, and it goes back to my last point, departments collect administrative data, very large, they cover the whole population, right? So this is not like it's an impossible task. If you're collecting this already and you're collecting it as a routine part of your daily responsibilities, you have the data potentially in-house. So I'm saying these are kind of workable, feasible
Yes.
things potentially.
Indeed. And just coming back to what Jill said and what you said, Ricky, and what Andy said earlier, is that are we hidebound here by what works to have action? And I ask that because, as you say, Andy, health is a complex system, isn't it? It's not like taking a pill, you then become healthy. There are many different wider factors. And are we just being too hidebound by the framing of we just act when we know what works? You know, all the what work centres that were set up and so on. Are we ever going to know really the full impact of what could be 50 different factors on health? Is there just more of a case for having more confidence for doing what, our best bet for improving, if we're going to improve resilience? Yeah.
I mean, it is a feature of complex systems that they are heavily laden with intrinsic uncertainty. Not just that it's not known, but it's not knowable.
Yes.
Until you do it.
Yes.
And that means you have to do it. To learn by the doing and engage in active experimentation, ex ante, and rigorous evaluation ex post. And the greater the degree of experimentation and requisite variety in approaches, the more you stand to learn and the better the system emerges. And that's a world away from the system we have right now, where the premium is on, don't waste my money with another failed project. Whereas actually, the flip of failure is learning and longer term improvement. So, whether it's the equivalent of the Education Endowment Fund for Health or some such that actively allocates monies towards experimentation of what works. That's happening.
Yeah.
The Marmot towns and cities are very much in that spirit. What's been done in social prescribing is very much in that spirit. But that's been initiated by individuals, not by the system.
Yes, and when money is tight, you can see why people lose confidence and they need evidence in front of them. And I suspect this might be at work with the Department of Health, that wants to have evidence-based policy used to an RCT in health, for example, how we examine the impact of science or technology, something quite simple, not a multi-system solution, which is the case here. We're running short of time, unfortunately. We could go on, couldn't we? But I must just come to one question, which is an old chestnut, which is the long-standing issue about short-termism versus long-termism. This is a 30-year agenda, isn't it, that we need to look at more data, we need to audit health more fully, we need to have a longer-term programme that will span more than one government. How on earth are we going to get some consistency of vision, possibly akin to the green agenda in this area? Otherwise, we're just going to be flip-flopping, aren't we, onto different policies? Could I just have a sentence from you all, which will probably be your last sentence on that?
Go on, I'll start. So we didn't say we'll reach net zero by everyone going away and having their own plan. You go away, Andy, you go away, Jill, you go away, Ricky. You get to net zero when you can get to it. You determine how much you spend, you determine how much you measure it. Come back to us when you've done it. We didn't do that because it won't work, because people start from different bases. There will need to be some kind of structure around this. And when I always say business can't pull all the levers, government can't pull all the levers, some of the levers they can pull is setting that framework within which business can go and innovate. So I'm quite keen for that kind of national commission, that reported parliamentary ear type function to exist, because without it, we won't emulate some of the success that we've had in climate, which is everyone broadly knows they're working to 2030 or 2050. There's no other option. That's your option.
Thank you. A sentence from Ricky.
I think from me as a data person, put the best data possible in front of the right people. So you need cross-party support, things, for example, like the pensions dashboard. If people kind of buy into it, make sure you get buy-in, leverage from the right people. That's the only way we'll get any success. Otherwise, I'm just being extremely naive in all of the cases. Yeah.
Thank you, Jill.
I think the sort of long-run incentive for politicians is they want to do other things other than just shovel money into the health service and have to sacrifice all their other priorities for that all the time. So I think it's sort of, there is a consensus that we need to fund the NHS. They just need a consensus on how we stop it eating up the entire rest of public expenditure in the economy.
Thank you. And Andy, the last word from you.
We need an ambitious medium-term mission around health and other things. underpinned in legislation, transparently reported on, and independently scrutinised to see if we're on the critical path towards it. That is sort of working for climate. There's no reason why it couldn't work for the other realms of public policy, including, perhaps even especially, health.
Well, that's a great way to finish. Thank you very much to Andy and all of our panel for a fantastic discussion and lecture before it. Join me in thanking everybody. Thank you. So I did promise that we might have some pop-up results from the polling, but I think we're probably running short of time. So what we'll do is we'll put that on our website to see if any of you change your minds during the process of this lecture. Andy will report that back to you. So thank you to all of you for coming, and to all of those of you who submitted questions today. It's a totally fascinating area, and you can see that this is not going to go away anytime soon. And I suspect the momentum will only build. And thanks to Andy and our panel for giving that a great fillip this morning. Just to remind you that the recording of the event will be on our website shortly, so have a look and maybe, as I say, show your friends. And yes, I think that's probably it. Thank you all very much and enjoy the rest of your day. Thank you.